In summary, staff your practice with passionate, dedicated surgeons and office staff. An employee with the lap band system in the practice can be a great resource to patients. Have adequate screening and assessment measures in place. Emphasize education, both pre- and post-operatively. Set realistic expectations and goals with the patients. Revisit them regularly. Keep an open door policy and a consistent schedule of proper adjustments. Encourage support systems, support groups, and family and friends. Encourage your patients' commitment to making lifestyle changes. And most importantly, follow up, follow up, follow up. In conclusion, keep in mind that a well-managed patient is a successful patient, and a successful patient is a patient who comes back to you time and time again. Your level of involvement with your patients is as important as their commitment to their new lifestyle. Keeping them motivated in difficult moments is as important as celebrating their success. Beyond patient education, follow-up visits, individual counseling, and support groups are part of your arsenal against poor compliance. And don't forget to suggest including your patient's family and friends in their plan for additional support. I hope the information I shared with you today helps you and your patients. We have developed a short summary in question and answer format at the end of this video to help you determine what you need for your practice. So stay with us just a few more minutes.
Thank you for your time. Number 1, foundation of success. What are the ABCs of success? A, adjustment of lap band. B, behavior modifications. C, commitment to success. D, dietary plan. E, exercise routines.
2, adjustment. Why is the band empty or partially filled initially? To allow for any edema to resolve while allowing the patient to adapt to the band during the first few weeks after surgery. When is the first opportunity for an adjustment after surgery? Usually 4 to 6 weeks after surgery. Why is the band slightly tightened at the first adjustment? To help patients feel more satiated and learn portion control in order to start losing weight. What are the reasons for band adjustment? Adjust the band based on level of hunger, amount and type of food that can be eaten comfortably and how long it takes them to eat, activity level, how much fluid is already in the band, and speed and the amount of weight loss. 1 to 2 pounds a week is ideal. When should the band be loosened? Loosen band if patients experience nausea or vomiting after eating, night cough or night reflux, recurrent respiratory issues, pain, difficulty swallowing, or inability to eat solid food. When asking them about food tolerances, you may find patterns of maladaptive eating if the band is over-adjusted. Some patients will mislead you in an attempt to keep their band too tight. What is the green zone? The green zone is when the right amount of fluid is in the band. It is comfortable and effective. The patient reports reduced hunger, not food focused or looking for food, slow, steady weight loss, approximately 1 to 2 pounds a week, portion control, small portions satisfy, able to eat most normal foods that are well prepared, absence of red flags or complications. How do you locate the access port of the band? Palpation is the most commonly used technique to locate the placement of the patient's access port for an adjustment. Make note in the patient's chart regarding the exact placement of the port.
Number 3, behavior modifications. How can you help your patients change their lifestyle? Ensure patient psychosocial support. Evaluate patient psychological status on an ongoing basis. Psychological factors provide clues that the healthcare team can use to identify at-risk patients and provide patients with early intervention and behavior modification tips. Utilize standardized evaluation tools and chart the results. Refer patients for psychological counseling or behavior modification therapy before risk factors become obstacles. Strongly suggest patients join a support group. What are the 3 most important items to discuss with your patients in follow-up visits? Follow-up visits should discuss: Number 1, eating behavior. Small bites, chewed well, swallowed with a minute between bites. Eat when hungry, stop when satisfied. Avoid snacking between meals, but plan for a healthy snack when needed. Consequences of eating fast or eating poor food choices, including development of complications. Continuous adherence and compliance to appropriate food choices. Number 2, incremental increase in appropriate physical activity and exercise. Number 3, timely and appropriate band adjustments to maximize satiety.
Number 4, commitment to success. How can you solidify your patient's commitment to success? Use techniques that have been proven successful. A contract. Have patients sign a contract that outlines specific goals, benchmarks, and strategies you have established together. Realistic expectations. Give patients realistic expectations. Compliance questionnaires. Develop and administer compliance questionnaires that incorporate subjective and objective measures of compliance. Identify risk factors that contribute to non-compliance in diet and activity programs. Educate patients on risk factors that might undermine their success and document this in the patient's chart. Create support groups within your practice. They need to meet patient-specific needs. Correlate frequency of support group meetings with benchmarks of success among your patients. Make support group requirement decisions on a patient-by-patient basis. Draw on the capabilities of a wide variety of office staff members or external professionals to facilitate support group meetings. Consider including the surgeon in support groups at regular intervals to discuss specific management issues. Use educational tools. Each practice should select educational methods and monitoring tools based on the patient's needs and the counselor's style and experience. Self-monitoring is a key tool with documented value in promoting weight loss and weight maintenance. What is the recommended minimum number of visits during the first year postoperatively? A minimum of 1 visit per month. Many programs schedule bi-monthly appointments the first few months. The initial post-op appointments should be scheduled before surgery. A very good process that successful practices consistently report is the requirement of scheduled visits. No one should leave your practice without the next scheduled appointments. Patients should not be advised to just call us or come in when they're needed. Rather, routine, frequent scheduled visits should be the norm. What factors in your practice could impact your patient's compliance? How available are you and your team? How welcoming are you to your patients who are doing poorly or have given up? How do you deal with problems of distance and relocation? How do you deal with those patients who do not keep appointments or are not being followed up? Do you send out reminders? Does someone from your office call and remind them of appointments? Do you try to re-engage patients? Do patients perceive value out of their appointments?
Number 5, dietary plan. Post-surgery, what is the time frame in the progression to solid foods? Progression may be as short as 3 weeks, but may last 6 weeks or more, depending on the patient. What are the 3 main stages of progression to solid food? Number 1, liquids. 2, pureed foods. 3, soft foods. Once patients transition to solid foods, what are the 8 tips that have been successful to help patients stay on track? 8 tips for success. Eat only when you are hungry. Eat slowly. Stop when you are feeling satisfied. Be active. Do not eat between meals. Eat high-quality food. Drink low or zero-calorie liquids. Stay on top of your aftercare. How can you help your patients improve their eating behavior? Design a dietary plan with them. The plan should include a detailed meal schedule, the correct food choices and portion control, how to implement and maintain these choices within the context of their daily lives. This is where the patients need you most. Educate patients about misconceptions regarding certain foods so they don't fall into the trap of what is perceived healthy, like cereals and salads. Designate someone in your practice to take on the responsibility of helping your patients maintain healthy eating habits. What is a 2 P's meal? A meal that includes protein and produce. Half of the meal should be lean, protein-rich food. The meal must be high in complex carbohydrates, produce.
Number 6, exercise routine. What does NEAT stand for? NEAT stands for non-exercise activity thermogenesis. This is what you need to focus on for your new patients. Have them increase simple daily activities. As patients begin to experience weight loss and a reduction of obstacles to physical activity, they can expand into formal exercise programs. For very large, super obese individuals, physical therapists or exercise physiologists should design progressive programs that account for patients' mobility issues. What benefits of physical activity should patients focus on? Burns calories, builds and maintains muscle mass and tone, suppresses appetite, provides better sleep quality, increases endorphins and energy levels, increases ability to concentrate, increases sense of self-control and builds self-esteem, improves appearance, reduces depression, reduces stress levels, increases metabolic rate, improves circulation, improves heart and lung function.
Number 7, minimizing unsatisfactory weight loss in your practice. What can your practice do to minimize unsatisfactory weight loss? Have excellence in preoperative preparation, patient education, realistic expectations. Have excellence in designing and implementing a patient aftercare program. Continue patient education, regular pre-scheduled follow-up visits. Decrease barriers to getting consistent, adequate follow-up and appropriate adjustments. Provide access to care in appropriate locations and times and at a reasonable cost. Provide regular monthly follow-up visits in the first year and routine long-term follow-ups, as well as easy access for acute or as-needed appointments. Provide a support group structure in your practice. Make it easy on your patients by designing support groups within your practice, and don't forget to encourage and have empathy with your patients. Have excellence in designing a back-on-track plan. Assessment of the reasons for unsatisfactory weight loss. Don't hesitate to run diagnostic tests to catch complications before they overwhelm your patients and become dangerous for his or her health. Have strategies to manage those reasons.
Number 8, complications. How can you be prepared for complications? Key to successful outcomes. Understand the signs and symptoms of short and long-term post-surgical complications. Develop diagnostic and management protocols regarding complications to be followed by all team members. What complications may be seen in lap band patients? Gastric outlet obstruction, erosion of the band into the stomach, tubing and access port issues. What are the common causes of gastric outlet obstruction? The band is too tight. Slippage or prolapse of the stomach through the band causes abnormally enlarged pouch of the stomach above the band. Symmetrical enlargement of the pouch above the band, stretching the lower esophageal sphincter, or the development of a hiatal hernia or esophageal dilatation. What are the symptoms of gastric outlet obstruction? Stasis, or gastroesophageal reflux. Sleep disturbances or respiratory symptoms. The presence of a chronic cough, recent onset of asthma, recurrent or prolonged bronchitis, or pneumonia may be related to outlet obstruction. Recent onset of these symptoms should alert the healthcare professional to consider the band as a possible cause. Abdominal pain is rare, but a major concern. If it does not resolve with the removal of saline from the band, immediate referral to the surgeon is required. What are the symptoms of erosion of the band into the stomach? Many band erosions are silent and totally asymptomatic. Weight gain may occur because the band is less effective. Development of late port infection is thought to be a late sign of a band erosion as bacteria has ascended up the band tubing to the access port. An upper endoscopy is indicated to look for a band erosion whenever a late persistent port infection occurs. What tubing or access port complications may be seen? Tubing or system leaks, access port infections. As previous, band erosion should be included in the differential diagnosis of late infections at the access port. Malposition or flip. What are the diagnostic protocols employed to manage non-urgent complications? Diagnosis of pouch dilatation, slippage, and prolapse is achieved by using upper GI series. The fluid in the lap band system should then be removed as an interim measure. Significant gastric pouch enlargement is addressed by revisional surgery. Erosions are typically diagnosed using upper GI endoscopy, and the eroded band is then removed. most often scheduled as an elective, non-urgent procedure. Revision of the access port is not considered an office procedure. This concludes our question and answer. Thank you again for your time. We wish you and your patients great success with the lap band system. Please don't hesitate to contact your Apollo representative if you need more information